Good morning. Happy Monday. I have Neuro Coffee in hand and it is perfect. All right. Man, very busy Monday coming up. Quick housekeeping item. IFAST University, we have call at 1 p.m. Eastern Standard Time today. Please join us for that. If you're not a member of ifastuniversity.com, please go to ifastuniversity.com, get yourself signed up, and then you can join us for the 1 p.m. call. Always great people and a really, really solid Q&A session coming up for today. Digging into today's Q&A, this was Zach. We had a case situation here. So we have a field hockey coach slash player with some situations, but what this does is it allows us to look at how we evolve from potentially reduced gravity situations. So say we're working on somebody on the table, we've taken gravity out of the equation to a certain degree, we're managing some of the internal forces, and then what happens when we stand up. And so how do we test for that? And so this is where we can introduce the load propulsion test, which is going to give us a representation of how an individual does manage the internal forces when we bring them upright compared to when we get somebody clean on the table. So Zach is very successful on the table with this individual, but having trouble in regards to this transition in standing. So we definitely go over that. So thank you, Zach, for bringing this up. It allows us to answer a lot of questions in regard to how people will progress their clients and their patients. Everybody have an outstanding Monday, and I will see you tomorrow. Zach, are we going to talk about ACLs today?
No, we're going to venture into just normal PT land with low back pain.
No, normal PT land. Well, Zach, if you have a patient that comes to you with low back pain, you just follow the low back pain protocol. Everybody knows that.
Yeah, it's just
because it's all the same.
And we're good to go.
You know.
So I had two patients that have come in the last couple weeks. Different like presentation wise as far as like archetype and chest boards, but similar like pain in terms of just, like low back, specifically with extension. So just trying to like figure out kind of like shapes where they are.
So when you qualify something like that, when you say specifically with extension, sorry, I choke on that a little bit. What do you mean?
When they lean backwards, that is one of the most provocative movements for them.
All right. So is it leaning backwards from standing, or is it coming up from a forward bend?
The former.
That means the first one, right?
Yeah. So they're upright and then go back.
Okay, gotcha. All right. The former ladder thing always throws me a little bit.
Apologies.
No, it's okay. It's okay. I'm just an idiot.
I don't think we would all come on this call if we thought that was the case, but
okay.
So anyway, the first woman, she was like chessboard wise. She's like a narrow, and she was on like a pretty hard turn to the right in terms of like.
1 second. Does somebody have a bird that they can mute for me, please? Thank you. Oh, good. All right. I know who it is. One second. I got it. All right.
So she was on like a turn magnification of the left IRs. As far
magnification, is that what you said?
Yeah, like just
okay.
left IR.
I'm with you. Totally with you.
Her pain complaints are more like specific in the sense that when she goes back or leans backwards, I'm not going to catch myself saying extension again. She was initially getting like right radicular pain, like shooting down the leg, like to the knee.
Yeah.
And then the other thing that really bugged her, so she's a field hockey coach. So whenever she was doing like the sweeping or shooting motion, if she's like, they all do it righty, when she would like transfer her weight to the lead leg, the left leg, it wasn't the actual swing, but then coming up from that, like even like with no weight on the right side, always on the left, but just
it's kind of like a follow through with a golfer.
Yeah, but
it's that side. It's that side of the.
They're way. She's like way hunched over, which she's totally fine. Like if she just stayed down there, she'd be totally fine. But then when she push through the left, she gets the right-sided symptoms.
Yep.
The other girl with low back pain is a college sprinter. She was kind of someone who just like had no gradient for movement whatsoever.
Okay.
And then while she had the pain with the extension, also like flexion, just a very limited arc of motion both ways. I'm having more trouble with her than the first woman. I'm trying to figure out like from a shape standpoint, because it's like, especially with the field hockey coach, I can like pretty much get full relative motion, or what I think is full relative motion, within the course of a visit. And significantly reduces her symptoms.
Okay.
In the sense that like instead of the pain going all the way down her leg, it's just kind of like localized to her butt.
Gotcha.
And she'll say that like the sharpness is gone, and now it's just more of like a dull like aching there. But still can't get rid of that pain. So I'm just kind of wondering, like from an influence standpoint, is this something that maybe like she's fooling me on the table? Is there's like tissue sensitivity that needs to resolve, even though I've gotten full motion, that's just a time thing? When I stand her up off the table, does she potentially lose what I thought I had on the table? So kind of like probably the question I didn't need to answer with both of them, but probably.
Who do you want to talk about?
Let's do the field hockey coach.
Okay. So if you've got the magnification of IR on the left-hand side,
yeah,
what would promote that?
The turn of the lumbar.
Yeah, I mean that's a big turn. It's a big turn, right? All right. Now, are you able to reduce that to something that would fall towards the average?
Yeah, so like for her, she was missing a lot of hip extension too. So I just started like in hook line, right
Yeah.
foot off the ground.
Okay. But you brought the IRs back to something that's a little bit closer to the average. Did you also reacquire the ER on that side?
Yes.
Okay. So you're doing a lot of the right things. Okay. Correct? Okay. Did you get the late hip IR to go to 0?
On the like specific
Negative
side?
Ober's test. Negative Ober's test.
Are you asking about a specific side or just?
Yes. The more difficult side, which would be the left side under this circumstance.
Yes, I did.
Okay. And it wasn't with an IR substitution of orientation.
Don't think so.
Okay. All right. What's confirmation for that?
Like another test.
Yes.
Would that be low propulsion?
Yeah. So you clean up the Ober's test, you put them up on their feet, and then you want to make sure that when you bring them up, that they're not losing that position, right? Does she lose the position when she stands up?
And not do the low propulsion test.
Okay. So it might behoove you to do that. Okay. That's going to give you your next step. So it sounds like you're being really successful. When you reduce gravity, you're able to recapture what you need to. The next question mark is, okay, do I still have control upright?
So
If you lose it upright, you know you can transition them from the reduced gravity situation to a little bit more upright, but you might not be able to bring them all the way upright. So now you might need to do something that's more reclined. This is where you're going to go, your heels elevated stuff, offset, staggers, chops, things like that, right? To reduce gravity in the upright position. Does that make sense?
Yeah. Can we go over the shape that's giving her the right-sided symptoms when she?
Does she have any right hip IR when you measure on the table at first measure?
Negative.
She doesn't have any.
Like 5 to 10.
Okay, awesome. So then you know that center of gravity is way forward. Okay, so you got to get her moving from right to left. Okay, and that again, I think it's very straightforward. So, but again, it's like this is somebody that is pushing forward. So the concern that you have is like, okay, you're like I said, you're great on the table. You're doing everything right. You just got to make sure that she's able to hang on to the same representation in standing.
So it could literally, like the change could happen that fast, like literally
Yes.
just on the table, fine. And as soon as I stand you up and just immediately do the test, like it just could be too much.
Yep.
Kind of crazy.
Why?
I don't know. Just
Okay, so hang on a second, boss. If I lay you on your back, where are your guts?
posterior.
They're laying on your back, right? They're actually promoting the potential for a delay strategy into the table, aren't they?
Yeah.
Awesome. If I stand you up, where do they go?
Down.
Yeah. And down and where?
Down and forward.
Yeah. Oops. Okay. So now you just took, so you had great heel contact. You had all of your foot cues. You had pelvic cues on the table. You had a thorax that was doing exactly what you wanted to do. You stood it up and her perception is like, oh, I got to go forward. I'm upright. And then boom, everything went down and forward. That immediately changes the muscle activity. That's why you want to make sure when you're transitioning somebody from a lower gravity situation to a more challenging upright situation. That's why the load propulsion test exists, is so I can see what happens when they stand up.
Yeah, no, that I guess I understood like in just baseline conceptually the low propulsion test and what, but like with that context now, it just kind of makes a little more sense as far as like the decision making of where it takes you.
Right. So the question mark, so the low propulsion is like, can I put IR into the ground directly below my center of gravity? Right? Or did my center of gravity go forward and I cannot do that? Right? That created a little bit of an orientation. Now I'm using orientation to create the IR, right?
Right.
Because that's what she was doing before anyway, right?
Yeah.
That was her interference.
So now can we just look at her like her sweeping motion with the field hockey stick and there a little bit, because like so if I have her do like a toe touch, she's not have any recreation of symptoms, feet together,
Awesome.
come back up, but now loaded on the front leg in like a toe touch position where she's hunched forward and then goes to push through the left leg, that'll reproduce her like she says it's mainly the tingling down the back side on the right.
Of her right leg.
Of the right leg, yeah.
Yes. Okay. So she wants to make a left-hand turn, correct?
Correct.
Okay. And she's got a
with the shot, or like her strategy?
With the shot.
Yes, left-hand turn.
Yeah, so she's trying to make a left-hand turn, and yet her entire pelvic orientation, spine orientation is going the other way. So I got a left side that's shoving me directly against where I want to go. And so now what do I have to do to actually get into that direction? Would I have to increase the degree of output on the right side to overcome the left side?
Yes.
And what direction will I go?
And you'll orient to.
So left side is so far forward. You've got a magnification of IR. You've got a spine that's turned to the right. You got IR that's trying to get jammed into the ground, but it's going that way, right? I'm going to take my hockey stick and I'm going to swing it from right to left, which means I got to end up in a delay strategy on the left side, and I do not have a delay strategy. Okay, but I'm going to push with my right side anyway, right? To get there, what direction will I end up going?
Kind of like up and to the left.
You're not going left anywhere.
Well, I'm just picturing a whole orient, like you just the whole body turning from that.
Okay,
way.
but technically speaking, if I'm pushing the right side, if I'm pushing with the right side against the left side that's going this way, what is my resultant direction? Say it. There was a little noise. Forward. Yeah. So that's where she started, right?
And then we're into the same issue that we talked about with just the when as soon as she stands.
Yeah. So she's got all that. She's going to create all that right-sided compression because she doesn't have the delay strategy to make a turn. So she can orient that way. So you're absolutely right. But the way that she's getting there, right, is not going to be a turn. It's going to be like she's literally taking both sides of her body and she's going to push forward, but she's going to make sure she orients that way. Did you look at her left foot?
Yeah, I can't picture it in my head right now, but I have a picture on my phone.
Not the left foot in standing, left foot in turning. Did you do a standing rotation?
No.
Look at her standing rotation. Feet together. Look at her standing rotation and watch her left foot. Does she have a history of a left ankle sprain?
No, but she's got a meniscus tear on the left side that she's about to get surgery on.
Okay.
No real she's an athlete her whole life, but no real injury history that she offered up. She's like,
you mean other than the meniscus tear and the back pain?
The what?
You mean other than the meniscus tear and the back pain, she doesn't have any history?
So the meniscus tear, she didn't even really know. So when she came to me, left knee was a little bit swollen. So I was like, all right, what happened? She's like, I have no clue. So in my head, I was like, all right, you're jamming. It's on the meniscus on the left side. So I was like, if you just jamming that left side into the ground, conceivably maybe that's just kind of irritating. So I was like, let's just see what sticks out. And it wasn't really getting better. So she went to the doctor, MRI. There's a meniscus tear there, but she doesn't know how it happened.
Yeah. She probably doesn't know how the disc is herniated either. Right?
Yeah.
It's a concern. It's a concern because again, she's got to create a delay strategy, doesn't she?
Yeah.
Yeah. So I would check her left foot's going to give you a little bit of a tell when she tries to turn to her left. Her left foot's going to give you some information as to how she's doing it.
In terms of the whole thing, will probably just
that would be my thought. Yeah.
All right, take a look at that one. I see her.
Good morning. Happy Tuesday. I have Neuro Coffee in hand and it is perfect. All right. A very busy Tuesday coming up. We're going to dig straight into today's Q&A. This is a question with Ian. This is actually an extension of a discussion that we had where we were talking about knees, and then that led us into a foot representation as we're pushing into the ground and how we would see a bunion evolve under certain archetypical situations. And then that led us back to the knee a little bit and a little bit of pelvis as well in regards to these force-producing positions. One of the biggest errors that we tend to make that results in some of these negative secondary consequences like bunions, knee injuries and such is trying to produce force through an externally rotated representation. In an ideal world, we want to have situations where we don't have rotations taking place as we're producing our maximum force. So if I grab my pelvis over here, so if we're going to talk about a force-producing pelvis situation, we're going to have the IR representation of the pelvis because there's no rotation going through the pelvis. That allows us to produce maximum force without a dissipation of energy. Same thing through a knee, same thing through a foot. It is only when we are not doing that where we're actually pushing through these ER representations where we get these negative secondary consequences. So Ian, thank you so much for this question. Truly appreciate it. It's going to help a lot of people. Everybody have an outstanding Tuesday, and we'll see you tomorrow.
Hi, Bill. I just wanted to go through when we were talking about when you start losing the first med head on, and I have the right side in my mind.
Okay.
And with the narrow ISA, because they start orienting from proximal to distal.
Say it again one more time. You kind of cut out a little bit.
Because of the narrow ISA starts orienting from proximal to distal.
Top down. Mm-hmm.
But a wide starts orienting distal to proximal.
Yes.
But because I have a hard time visual, I can see with the narrow, they will start with the proximal femur and then they will just superimpose the ER until they get to the foot and the big toe will come off. But with the wide, because they're still getting pushed forward, that's towards late. And in late, the big toe is the last one that it's on the ground. So I would see the bunion forming sooner on the wide, maybe because the first med head stays and everything else rotates relative to it as the weight is translating forward.
okay, you're going to see you're going to see the differential mechanics. Okay, you're going to see the IR. So if we're talking about a bunion, we're talking about the IR at the metatarsal, and then the ER at the.
But I'm getting the other representation with the wide, right? Because I'm getting ER of the metatarsal, and the first toe is staying in IR. That's more of the bowed-legged.
Okay, so what I'm saying though is like you're going to have like a normal, you're going to have the normal mechanics, right?
Yeah.
That will last longer. Like I will have that normal representation that will last a little bit longer. So if it was a wide ISA with a bunion, it's going to be the superimposition of the late that's going to create the bunion, because they have a middle representation where this twist is taking place under normal circumstances. They're going to be driven so much harder into the late representation to create the bunion.
All right.
Are you following? It's like, because they're going to go through middle under normal circumstances. So they get a normal rotation, right?
Yeah.
But as they get pushed further and further into late, and that heel starts to break from the ground more, they get the ER coming from like heel to toe, if you will.
Yeah.
But the toe is going to stay down longer. That's what's going to create the bunion representation there.
It's gonna stay down longer, but it's gonna be
yes.
ER.
Yes.
Right.
And then the ER is gonna, so they're gonna have the ER is gonna lift the foot up, but the metatarsal head stays down longer.
Yeah, but it's gonna be on the ground in the ER representation.
Yes.
The IR is just the weight pushing.
Yes. Yes. Because right. Again, their middle representation is a bigger space of time.
All right. And the thing you were talking about with Thea, it's awesome to visualize. It's something, the knee is it is a pelvis, but we actually get like in mid, we just get it to face forward, just like the sacrum. So, all right.
Okay. Think about this. Okay. In an IR pelvis, I don't want any rotation.
Yeah.
Do I want, because that's my force producing pelvis.
Got it.
Okay. In an IR representation into the ground through a knee, do I want rotation?
No.
See, it's coherent, right? So that knee is, if I look at the knee as half of what the pelvis is doing, I need the IR to go straight down into the ground. I don't want the differentials. The storage and release of energy, though, is creating that differential. So the timing of it has to be that when I'm pushing hardest into the ground, that's where I want that knee to be as square as humanly possible.
Got it. And
you don't want to push into the ground and screw home.
Yeah, I'm doing that, so you can.
Well, you can do it. It's just that's what I don't want.
Yeah, right? It's when I go from the square to the front knee, and when I get the initial, like the eccentric overcome of the connective tissues, I will get the foot that starts releasing energy up. And I will get the proximal tibia that starts ERing again relative to the distal femur, right?
Yeah. Yes, it's gonna come up it's gonna start coming up from the ground. Yes.
All right.
Yeah.
All right. And
that's where you go. That's where you go towards screw home.
Yeah. That's when the connective tissues start releasing energy. So from that point, the connective tissues start releasing energy and everything starts ERing again. But with the squat we were talking about with Christian, I'm creating this scenario in the foot, but because I'm translating my knee forward and I'm not extending it, I'm actually flexing my knee. I'm going down. I'm creating the IR tibia. So yeah, all right, that's it. I'm gonna let others
because you need the down pressure.
Yes, sir.
You need the down pressure. So it's got to be where I have a really strong super superimposition of IR.
Got it.
Yeah.
Got it. Thank you.
Good morning. Happy Wednesday. I have Neuro Coffee in hand, and it is perfect. All right. It is Wednesday. That means that tomorrow's Thursday. That means tomorrow morning, 6 a.m. Coffee and Coaches conference call. As usual, I believe this is number 111 of these calls. We're getting pretty good at them, so you should probably join us. Grab a cup of coffee. Great Q&A, great people, great questions as usual. Lots of good information being passed around. So again, please join us for that. Digging into today's Q&A. This is a question that came from Paul. He's very apologetic. It's kind of funny at the very beginning of the call where he feels like he's interrupting. It's like that's what the call is for. But anyway, Paul's question led us into one of my favorite concepts to talk about is like dirty table tests. And when I say that they're dirty, it just means that what you think you're measuring, you're probably not measuring. So when we're measuring a hip, we're not just looking at the hip joint itself, even though that's what has been expressed in many of the teachings. What we're actually looking at is the femur's relationship as it moves relative to the innominate movement and position in space, the sacral movement and its position in space, the spine movement and its position in space. So all of those things are influences. Which again, that's why the chessboard becomes so important, because we can actually identify these relationships, so we can actually determine someone's physical shape relative to the table. But this is also why some of the traditional measures, like using motion-palpation tests where we're palpating bony landmarks, can actually create confusion or can actually help us identify things. And so Paul's question kind of led us down that path, and so we break that out a little bit for you. So again, it's going to be very useful, especially for those of you that are doing traditional measures on the table, as we would in, say, a physical therapy environment. So again, thank you, Paul. Everybody have an outstanding Wednesday. We'll see you tomorrow morning, 6 a.m. Coffee and Coaches conference call.
Bill, I'm so sorry. I have one quick question related to the wides and narrows having a left side that's either higher or lower. I just made all these little light bulbs go off. With the Schamberger paper and the Dunnington papers you have us read, is that kind of what you were getting at? Like the whole thing, leg lengthens, lying, landmarks lower. Is that, you could still use that, but that would help you identify a narrow versus a wide, potentially?
Okay, perfect word. You literally took the word right out of my mouth. Potentially, yes. Here's
Okay.
the problem. Here's the problem. You got somebody that's laying on a table. The degree of the turn. So think about this. So take somebody that's really twisted and turned and bent and compensatory out the wazoo, right?
Mm-hmm.
They lay on the table and they're still in that position. Can you see how, like, so if I get somebody that's on a right oblique,
Mm-hmm.
and they stay, there's like, it's such a strong representation that they're laying on the table in the right oblique. Okay. Now take that right oblique. Okay. Very easy to identify, but this time they fall back to the table.
Mm-hmm.
So if they stay in the right oblique, the right side of the pelvis looks like it is more forward, right? And the loss of ER on that side. If they fall back, the left side's going to look like it's going to be more forward based on traditional representations. This is the problem with motion palpation tests, is because they're inconsistent, because you don't know what representation is laying on the table. Like, is it somebody that's staying in this orientation, or are they falling back against the table because of the direction of gravity and the surface?
And falling back, let's just say with that left side, that would come from the spine in the form of what, an IR?
You would magnify. So if the spine turns,
Yeah.
like if I'm measuring left hip and the spine turns towards me, that's going to magnify the ERs. If it doesn't turn, then it magnifies the IR representation potentially, depending on how far they turn. So then we're back to Zach's question about the field hockey coach.
It would magnify the ERs if the spine turned.
So if the spine, if the lower back can turn towards, so I'm standing on somebody's left side and I'm measuring left hip. Okay. If the spine turned towards me as I move the hip, okay, it's going to turn the whole system towards me as I turn the hip. It will magnify the external rotation representation of the hip. because I'm not just moving the hip, I'm actually moving the spine. So as I try to,
the,
you see it?
the low back is showing is going to face you. The
Yeah,
sacrum away
yeah,
from
like
you.
it was facing this way. I move the hip and it turns like that, and it just magnifies. So this is like the person that walks in and has like 70, 80 degrees of hip external rotation.
Okay.
Okay. If it doesn't turn, they have a reduced ER, and then it tends to magnify the IR if it's forward enough.
Okay.
Okay.
Alrighty. Thank you.
You're welcome. Good morning. Happy Thursday. I have Neuro Coffee in hand, and it is perfect. Yeah.
Also, this was helpful thing too. Moving on with the shopping spree. If we're thinking of like a nice little square when we're looking at someone from above, this is their
Yes.
base of support.
Yes.
Like this is the most oversimplified I can come up with, but I find it useful with like clients. So I just want to make sure if it's decent enough of but not too like the Einsteinian thing, like simpler but not too simple, like as simple as possible but not simpler. So
I'm a big fan of simple.
I do know that. So you have this like base of support, right?
I'm with
and
you.
like the way narrow deviate is like you will go forward on the left first, and then they will move over to the right. So like they end up with like quote unquote their like lower left corner superimposed like at end game, like kind of over the right
I'm with
top.
you. I'm with you. I'm with you.
And but they do that by kind of like going up and then to the side where
They go down. Hang on, down and forward on the left, and then.
oh yeah, I set up, but I mean like the they go forward with the left and then they go to the right.
Yes.
Yeah. Like when we look at like, let's say
It's always a ride downward. Okay.
indeed, because that's
With the
an
narrows.
motion to the
They're
ground.
gonna they're riding they're taking a downward curve, right? Yeah.
Okay, yeah. Where with like it's not as simple as that, but let's say the wide is kind of going over to the right and then kind of like down and oblique into ooh, that was loud. They kind of so they go over their right and then forward and obliquely over their right. Does that make sense?
No.
Okay, go ahead.
Somebody's laughing at
Yeah,
Dawn,
it's
Dawn, is that you
Dawn
laughing?
Taylor.
Is that Dawn laughing? Is that
Yeah,
Dawn?
she got caught
Okay,
right there.
I sorry, Don, I had to mute you because you're giggling and you're making Alex feel bad about himself. No, so when you so the starting center of gravity is not just the dot on the ground; it's also up and down, right? So
Yeah.
your wide ISA individual is going to start downward and he's going to move up. Okay, so they're going to move up on the left side. That's what moves them over towards the right, but it's right posterior first.
So
Okay.
at first, like their back pocket on the right will go back.
So if I do that, so there's the oblique turn. You see, so heels of my hands. Okay, watch the heels. You see how this one's back farther? That's where they go, and then they're gonna go like that. Okay, so they'll go like this, and they'll go like that. Okay, all
Wonderful.
right. You see the difference?
Yep. Yeah.
Yeah.
Now, last item at the very end, like in the freezing area, we got the milk, we got the eggs, we got all we need.
Always stay on the
Cart is full.
periphery of the grocery store.
Of course,
Okay.
you gotta stick with the image. And so like now I have a client where I've been trying to get her to feel her hamstring, and it's not happening whatsoever. And I'm so like I was trying a lot of sink squat variation or setup, and like none of that is going on. She gets like whenever I put her in a sink squat, she do manage to get her
A what squat?
abdomen
A what
sink,
squat?
sink squat.
Sink squat.
Yeah, so like her heels are elevated. We're trying to capture like early foot and pelvis.
Yeah.
And then she just has like her hands on something as if someone
Oh,
was
she's just
like,
holding on to something?
yeah.
I gotcha. Okay.
Yeah. I think
Okay.
yeah, it's a man that calls it that way. But
Okay.
I think he's working in Las Vegas or something, but he shall
He's
not
what?
be named. He's working in Las Vegas.
No idea who you're talking
Anyway,
about.
no, anyway. So that's what I was like trying to do, just like drive a bit of like posterior lower rib cage extension. She still gets knee pain with that, but she does get a bit of hamstring with like a wall sit with like a reach and yep.
Why are you pushing this hamstring thing? What are you trying to accomplish?
I'm trying to capture like early hip flexion.
Okay.
Like she's a wide, she's very like very push forward, and
Okay.
not much. Oh yeah, I didn't give any context about her. And like it's someone that has a longer term goal of changing her body comp, but there's not much movement available. A lot of stuff doesn't look good enough to me that I'm like, yeah, let's do it repeatedly with fatigue, and I have like no ethical concern. So
Okay.
I'm trying to expand movement option.
Okay. Hang on a second, boss.
Yep.
Are you more likely to capture an earlier representation on a symmetrical stance activity or an asymmetrical stance activity for wide ISI?
Probably asymmetrical.
Start there. Okay. Start there. That's what I would do. Especially if you're struggling. Right. So you put her in like a heels elevated thing. You go, this is going to give her some space back there. It's like, not so much.
I already do stagger the feet.
Okay. Switch your stagger and see what happens.
Left forward.
Hang on. Let me offer you something really crazy simple here.
Go ahead.
Okay. Box squat. Above pelvis above knee level. Okay.
Oh yeah, for sure. Yeah.
And then stagger her left foot forward.
Okay.
All right. And make her get up using the right leg.
So like get down both leg and then go over.
No. You won't even have to do that. You won't even have to do that. Okay. Just stagger her left foot forward, right foot back. Okay. Sit her down on the box. It's like I said, it's an easy box to get off of. So it's like the hips are above knee level. So it should be a fairly easy box to get off of.
Yeah.
Okay. And then teach her to push with her right foot. Okay.
Okay.
Think about what we just talked about. Okay. Take me through the sequence of a right oblique that went on the right oblique first and then went forward. Use your hands. Hold your hands up.
Yeah.
Okay. So why did I say? Okay. There you go. There. Okay. Stop. No. Stop. Okay. Go backwards one step.
Yeah.
There you go. That's what I just told you to do.
Okay. So we're going from this to that.
Yep.
And then we'll go back to.
Yeah.
Okay.
Yeah. Do you see it?
Yeah.
But you got to start high. You got to, like I said, it's got to be a fairly easy box to get off of, because she probably doesn't have a lot of space. But and again, your stagger is not going to be like that. It's going to be, something like this.
Yeah.
Okay. But if you start high enough, she'll be able to push down into the ground on that right side, because that's what you're trying to capture, right? You're trying to get her center of gravity. You need to move her center of gravity back towards her right heel first. Okay.
Okay.
All right.
That makes sense. Yeah.
Well, again, it's whether she's got the available space. I'm giving you an option. I'm not saying yes, I'm not saying no. I'm saying that was the thing that popped into my head when you were talking about, like, you were doing the sink squat, right? And so you were trying to create a delay representation, but the delay's in the wrong place. You're trying to create a delay at the sacral base. I'm going to create a delay at the apex. Do you understand the difference?
Sure. Where's the apex?
The apex is the pointy part of the sacrum.
Oh, like the okay, like the lowest part, like where you.
Yeah, hang on, boss.
Okay.
Hang on. Let me just grab my pelvis here. So your heels elevated strategy was trying to create a delay up here.
Yep.
I want to create a delay down here first.
Okay.
So I want her to go that way.
Yeah.
You see it?
Yeah.
Okay. And again, I can't tell you how much stagger to use, and I can't give you the exact box height, but like I said, if you start her there, and all you got to do is teach her to push down into the ground, right? With her right foot, capturing the appropriate contacts with the floor. And if she can do that, you will have moved her back on the right side.
So would
Then
something like
then flip-flop her stance. And maybe you do it with one exercise.
yeah, okay.
See it?
And then my KPI to know when time is to switch is when we get a more symmetrical sense of capturing medial foot contact.
Okay, which
'Cause
represents
right now,
which represents what motion, just so we're clear on this, because we got people that do table tests that listen to these. So if you're doing a table test, what would be your table test to tell you, okay, it's time to make the left turn?
to make the left turn, I would end up having more ER on the left, more IR on the right at the hip.
Boom.
Yeah.
Yes. Right. Because all you're doing is
It's fun. It's fun to do shopping with you, Bill. We'll go on many more shopping sprees. Cool.
No, but this is really good. This is really
Yeah.
good. It's like you get it. You get it. So again, this all you're doing is reverse engineering. It's like if you okay, foundational archetype tells you where she starts. Okay, the end position tells you how she got wherever she is, and then you just work backwards from it, right? Okay,
Yeah.
and you don't have to get crazy complex, right? Like you got all these goofy arm and leggy thingies. It's like just get the center of gravity in the right place. Like we're going back to Matt's question, right? Where are you going to put the weight? It's like, well, what do you want? Where do you want the center of gravity to go? Where do you want her center of gravity to go? Awesome. Put her on the high box. Put her in a little bit of stagger.
So she's very, very diligent and disciplined to
Yeah.
fine tune a little bit of what I asked her to do at home. Like she says she has enough time for like 1 or 2 reset a day. Like just something as simple as like maybe a side lying breathing with maybe a little bit of like kind of like the reaching motion with the left. And like maybe some hook line with a little stagger with that.
How about we just simplify this and say, you know what? Put a couple pillows on a chair, sit on the chair, get up with your right foot.
Okay, cool. Let's just keep it as just okay, cool. First
Okay,
production
hang on a second.
right leg.
Hang on a second. We can complicate this just a little bit and probably be a little bit more successful. Okay.
Yep.
All right. What do you want her to do as a breathing strategy? As a breathing strategy, what do you want her to do as she's doing this high box squat in the staggered stance?
I would like for her to inhale going down and exhale going up.
Be really specific about that. Be really specific about that. Okay. All right.
You mean even more specific than that?
No, just make sure that she's.
Oh,
she's,
yeah. Yeah.
Chances are she's going to hold her breath. Okay. If she holds her breath, show's over.
Yeah, I know that.
Okay. All right. Like I said, you're trying to recapture relative movement. You can't have her holding her breath. So if the box is too low, she's going to hold her breath, right? See, this is what I'm saying. It's like you if you coordinate this thing the right way, it's like you've just simplified her life, and in regards to all of the homework that she's going to have to do.
Yeah.
Now,
Okay.
no matter what I say, run the experiment and make sure it works first.
Of course.
Then you can get all cute and fancy if you need to. Okay. In most cases, you don't have to get too wild and crazy.
Yeah. Very cool.
Okay. Good morning. Happy Friday. I have Neuro Coffee in hand and it is perfect. All right. For those of you on the 2-week sprint, this is your rest and recovery weekend. Time to reflect. Make sure you are on point with all of your intentions and goals, if you will. All right, digging into today's Q&A. This is with Alex. One of the things that we need to understand is that when we're talking about movement, we're talking about shape changes, and there are situations that will arise mostly during treatment-related issues. Sometimes with your athletes as you're working with them in the strength and conditioning environment, where they will have difficulty promoting a shape change. And under those circumstances, we need to apply some form of manual therapy or some sort of physical contact to help them and make the change or promote the change. And so that's what Alex's question is about, because we talk about bony shape change. That's actually an influence. It will always be an influence. It's just part of the normal process. How we arrive at making that favorable change is just dependent on whatever strategy is presented to us, and then we have to apply a technique. So this is why in your early years as a physical therapist or something that would be similar to that, your job is to accumulate tools to give you access to different places and spaces so you can be effective with your manual therapies. Superimpose that upon an effective model for your clinical reasoning, and then you've got some superpowers to work with. So this is a really good explanation of how manual therapy may be applied. We actually talk a little bit about spinal stenosis as well, to throw that in there. So Alex, great question, great conversation. Thank you so much for your participation. Podcast will be up on Sunday as usual. Have a great weekend. I will see you next week. Alex.
Morning.
Greetings.
So, I'm wondering if you can influence any bony adaptations that might happen, like any sort of spinous transverse process in the lumbar, cervical, thoracic spine, with like PA mobs or rotational mobs or something like that. I mean, we talk about bony adaptations everywhere else and how you can affect those. So I'm just wondering if there's any there going on.
Yeah. There you go. Problem solved. There's your answer. Yes, you can.
All right.
Okay. Hang on. So let's talk about this, because it falls into like a little bit of a generalized category in regards to the application of manual therapies, right? So what kind of a force are you going to be applying under almost all circumstances?
PA.
Yeah, but I mean, it's like, can you directly apply external rotation? Yes, no.
Can you directly apply external rotation?
Yeah, is there a manual therapy?
No, not really.
Okay, right. Okay. So you're always going to be applying some form of compression, right?
Yeah.
Now, if I want ER, and we're talking about like a spine or a bone or something like that. If I want ER, I have to apply an IR force somewhere to get a response to create the ER. So that's how you would do that. And so as long as you understand like the bony orientation that you're chasing or a shape change that you're chasing, then you just need to make sure that you're applying the force appropriately. Mm-hmm. And so when you look at like a singular vertebra, it's just a fractal representation of a person, right? It's just a little man, right? It's got 2 arms and 2 legs, it's got a tail. And so when you apply pressure in the right place, you're going to promote potential movement, okay? But definitely you have influence on shape change. So, okay, what is when they talk about spinal stenosis, what is that?
Narrowing.
Okay, which way does it narrow? Just curious.
Well, there's a couple ways. I mean, it depends on where the narrowing is.
Okay, so we're talking about like the spinal canal, typically, right? Which way is that narrow? Which way is it narrow? Just curious.
Back to front.
It's AP, right? It gets compressed AP.
Yeah.
Strange, isn't it? Think about it. Anterior posterior compression. Does that sound familiar?
It is strange.
Always seems to go in that direction too. Like if you ever see like MRIs of people with spinal stenosis and lumbar spine, it tends to be an AP compression. Like I don't think I've ever seen one that was narrowed laterally. So, do you think that spinal stenosis is a bony shape change associated with a muscular strategy?
I would say that.
Okay, so what movement are you trained as a physical therapist to avoid in a circumstance of spinal stenosis? By tradition, you can even use the traditional
Extension.
Yes. So they tell you, okay, so what is that in reality that we know of, right? What is that? Is that ER or IR? It's IR, right? Awesome. Because they're already trying to compress into IR. In fact, they're making a bony shape change into IR under those circumstances. So it behooves you to not use an IR strategy to try to resolve that. And so that's where they came up with all those forward bendy exercises to try to reduce the influence of the spinal stenosis, when the reality is it's like, hey, if we can get some of that AP expansion, we can actually reduce the strategy that was probably promoting the bony shape change in the first place. That's my perspective. Okay. So to answer your question, it's like, can you affect the bony shape change? Well, a muscular strategy certainly seems to be able to do that, because this is something that happens over time. People are rarely, it does not that it never happens, but rarely are these people born with you usually see it somebody in their 40s and 50s, right?
Mhm.
And so so your manual therapies can certainly influence it. Okay. But again, it's having some recognition of what the representation is, so you are applying these therapies appropriately to promote the appropriate shape change. So when you have somebody that's turned, okay, and if you can appreciate the fact that the bones are probably, like bones twist, they compress, they expand, they elongate, right? And so if you can appreciate the fact that those bones are probably going to be following the physical shape of the turn as well, then it's a matter of applying pressure in the appropriate manner to oppose that. So, the rotation itself kind of helps you understand that. But again, where you put your hands is going to matter. And this is one of those reasons why I think that in many cases, therapies will work or they won't work. Right. Because again, I'm not saying this is easy, because it is somewhat difficult, because you're looking at things on such a small scale relative to the big picture, but at least the big picture can help you identify where these things might be.
Yeah. So in the situation in which someone is turned right and have maybe a bony adaptation keeping them there, you can grab hold of like the transverse process, or you can push the transverse process, kind of grab hold of the spinous process and an IR force getting it to turn, but you can't really grab underneath.
It's difficult.
So in that situation,
you can use ribs. So you hang on. So you use ribs to think about this. So you think about your sequence of events. It's like when you're untwisting a knee, and you're applying pressure to a tibia, you're influencing the position of the femur as well. Okay. So if I'm applying pressure to a rib, okay, when you ever have those people say they come in and they go, they've been treated by somebody else. They go, yeah, they said my rib was out, and they push it back in and it feels good for a while. Right. So those are just shape changes that are associated with the positions, right? So if somebody applies an IR force to an ER representation that actually makes an influential turn, a favorable turn, they restore relative motion, at least temporarily, right? That's kind of what you should be thinking. Is like, this is an adjunct to the things that I'm going to do to help you learn how to control this position versus defaulting into it, right?
In that situation, I might like apply an IR force on the right side and then grab maybe like the your lower ribs on my,
Yes.
like from the front
Yes.
with my left arm, and it help facilitate the whole thing.
We do that all. So there are okay. Do you have an osteopathic manual therapy textbook?
No, should I?
Yes, get one. Because everything that you just said will be in that textbook. Like there's a lot of stuff like that. So
I'll do that in sideline.
yeah. There's a lot of good prone mobilizations that work really, really well in regards to what you're describing.
Is that in the Greenman's manual textbook?
Yes, sir.
Okay.
It usually it's been a long time since I've looked at Greenman's, but that's a pretty good place to start. I've got, I don't know how many I've got a few, but those techniques are useful because again, all you're doing is you're promoting the shape changes, but you're using the relationships, just like we're talking about. It's like you apply pressure to the posterior rib cage, right? You're going to promote a compressive strategy. You're going to get the response of expansion elsewhere. That's going to promote the turn that you're seeking, which will potentially reduce the concentric orientation that's promoting the turn in the first place. Yeah, they work quite well.
Yeah.
As they're not the solution, but they will buy you space to work in, for sure.
Okay, that's really helpful.
Yeah.
As far as the stenotic spine goes,
Mhm.
I mean, I understand how if you lie someone on their side, you could potentially get AP expansion, but there's not that much force directly going into the vertebrae, I would assume, to directly induce a shape change.
Really?
Like you would with the pelvis, like you get the direct pressure on it.
Yeah.
Um,
You mean your application manually? Is that what you're saying?
well, so just, I mean, yeah, I don't really understand how you would apply it manually at pressure, I guess. Sort of like going in there and squeezing.
To create the AP?
Yeah, at like the spinal canal.
Oh, your job under those circumstances is to reduce the influence of the muscular activity that's creating the pressure. That would be your best case solution.
Mhm.
Now, having said that, there are some manual techniques that you can use where you can actually get between the segments, okay, and reduce the muscle activity between the segments. You know, your little intertransversarii muscles become concentrically oriented as the bones approximate. They're going to pick up concentric orientation, and so you can actually get your thumb in those spaces, right? And you can apply a force upward or downward and create a turn there as well. Okay. Now those are a little bit more. It's a little bit more. It's deep, so it's got to be a little bit more careful. It's a little sensitive, right? But it's doable. It's very doable. So you can access those spaces.
So for the most part, in that situation, you're just trying to get the bony shape change through the reduction in concentric orientation.
Yeah. So you take away the muscular behavior that is creating the compression, for sure. Yeah. Yeah. But I mean, you would do that in any number of different scenarios as well, right? You want to reduce, whatever you would like, just look at what you do with like vastus lateralis. Like, okay, I got to reduce the muscle activity there so I don't get the ER pull on the patella, as an example, right? So again, from a principle standpoint, it's not different. From a technical standpoint, it's just a little bit more difficult to access, but it's doable. It takes a little bit of patience. Okay. But like I said, it's like when you're successful, you immediately buy space to play in. And that's what you're trying to do. You're literally trying to create that space. You're not looking at it as the solution. You're looking at it as a component of the solution. Okay.
Right. Awesome.
Okay.